The topic is the first introduction topic is on atrial isomerism, and afterwards Laurent will give a specific talk on abnormal venous drainage. Please, Giulini.
So we're back again. I think we've already heard quite a lot of things today which are related to isomerism, starting from assessment of situs. Rabi has touched on a lot of things that I'm going to talk about now, but I don't think it's a bad thing to hear things again because we sediment knowledge. And the sequential segmental analysis, I'm going back to Rabi again when he put his crystal ball and said the myth of fetal echo. He calls it transposition, we call it concordant AV and discordant VA connection. But actually, when we come to some of the diagnoses that we're going to show you here in isomerism, there is no single word that can describe the heart. You have to go through it in a sequential way, otherwise you get lost. So the sequential analysis will look at three cardiac segments, the atria, the ventricles, and the arterial trunks. And we'll look at two connections between the atria and the ventricles and between the ventricle and the arteries. You can see as well the connections with the veins with the atrial chambers. And as far as this talk is concerned, we are interested in the atrial chambers related to isomerism because that relates to the situs. And the situs basically meaning position. So the cardiac situs is to do with the atrial arrangement. We've seen lots of pictures today of right and left atrium, and this is a morphological specimen cutting through the atrial chambers, which shows nicely the right atrial appendage and the left atrial appendage. And you see that the right atrial appendage is heavily trabeculated, a little bit like the right ventricle. They're called pectinated muscles, and has a broad base, while the left atrial appendage is much smaller, is a finger-like structure, and it has much less trabeculations. So it's all very nice looking at that in a heart that has two different, distinct atrial appendages if you have the heart in your hands. So the normal sites, what most people would have, is therefore called usual atrial arrangement, and that's the same picture as before, the right atrium, morphology on the right side, the left one on the left side, and that's what we call situs solitus. The opposite of that, the mirror image arrangement, is exactly a mirror image picture. So the left atrium appendage and the left atrium will be on the right side, and the right atrial appendage with the right atrium will be on the left side. And that usually, the situs inversus totalis, everything is a mirror image within the body. And then we have two other situs. So there are four types of situs as far as the cardiac situs and atrial arrangement is concerned. So in that group, we have the isomerism, which is the topic of this talk, and which is also called situs ambiguous, because neither solitus nor inversus, also called visceral heterotaxy, asplenia, polysplenia syndromes, so lots of words. So what is isomerism? Well, from the chemical compounds, you would have recalled from your old days of chemistry that they are compounds that have the same structure, but they are mirror images of each other. So if we come to the heart, and this is obviously a Photoshop-created image, if we look at the heart that has right isomerism, you would have two atria where the appendages are right-side looking, so the right atrial appendage. Life is not perfect, so the two appendages, they're not absolutely the same if you look at the heart, but they have more of the characteristics of a right atrial appendage. The same applies for left atrial isomerism, where the two appendages would be kind of a finger-like structure. I haven't drawn you a picture of that one. So the atrial arrangement is all very nice to understand what it is, but in practice, do we always see the appendages? And the answer is no. We don't need to see them the whole time. In children, when we want to look at the situs, we don't go on trying to image the appendages, let alone in the fetus. So in this picture here, we can actually kind of get an idea of right atrial appendage, a broad, and a left atrial appendage, a bit more narrow. But in reality and in practice, what we do in the child, and we do also in the fetus, is to infer the atrial arrangement by looking at the arrangement of the abdominal viscera and vessels. That is stomach, the venous channels, aorta and inferior vena cava, spleen, if you can image that. I'm not good at imaging spleen, so I don't look at that. So you do a transverse cross-sectional view through the abdomen, as Rabbi has alluded to before, and you kind of divide that in middle, and the normal situs, you would have the aorta to the left, the inferior vena cava to the right, the stomach in its usual position on the left side. And that, from that image, you can reasonably well infer, as a rule of thumb, that the atrial situs is going to be normal. So we look at that at the relationship of the abdominal vessels at the level T10 approximately, and as we've shown here now in a diagram, this is right side and left side, they're just mirror image of each other. So unless you work out right and left of the fetus, the image that you get of the abdominal circumference is going to be absolutely the same. So these are just examples of a baby with usual arrangement, and that a big right atrium on the right is inferred from here and a little left one on the left. And this one working out that this is the right side, the stomach is right side, the aorta is to the right, inferior vena cava is to the left, and you would have a mirror image arrangement. And then you may or may not have a cardiac abnormality associated with that. Well, in the usual arrangement, we don't think too much about that, but liver is to the right, stomach is to the left, spleen is there on the left. Here's our cardiac situs. We also have a thoracic situs in which the right lung has 3 lobes, the left lung has 2 lobes. The right bronchus is short and wide, the left lung is long and narrower. And the position of the bronchus here in relation to the pulmonary arch is different as well. So that's the normal. So the situs applies to the whole body. Of course, the mirror image arrangement, you have a mirror image of everything. It's a complete situs inversus. Now, when it comes to isomerism or situs ambiguous, we do the same in terms of the assessment at the level T10, which is more or less where you have your stomach in the abdominal circumference. And the right isomerism, you have the 2 vessels, aorta and IVC, more or less the same side of the spine. Now, they can be on the right or the left side, doesn't matter. And in left isomerism, you don't have an IVC in the majority of cases, but you have a prominent azygous vein. So you have the aorta, usually rather central, but maybe more to one side, and the posterior azygous vein. Again, this can be on the right or the left side. Yeah? So it doesn't matter. It's the arrangement that matters. So 2 examples. Right isomerism, our line dividing here, 2 vessels to the same side. Stomach here on the left side, but as Rabbi had pointed out as well, sometimes it's more central, like in this case. It's sometimes quite a small stomach as well. So that's an example of right isomerism. Left isomerism, see this very central stomach here, small again, aorta rather central, and a posterior azygous vein. So from these images alone, we can infer how the morphology of the atrial appendages are. So the same applies to the other organs. If you have right isomerism, the liver is quite often midline structure, and so it is in left isomerism. Right isomerism, you don't have a spleen, because a spleen is a left-sided structure, so you have duplication in a way of right-sided structure. So in most cases you have asplenia. In left isomerism, you're duplicating left-sided structure, so you have lots of multiple spleens. There is our atrial arrangement here with our usual appendages. So we have 3 lobes on the right lung, we have 3 lobes on the left lung, and we have 2 right bronchus, and we have 2 left bronchus, and you can see that on the chest radiograph. So in the child, when we have doubt about the situs, the easiest way of looking at that for sure is to do a deeply penetrated chest X-ray and look at the morphology of the bronchi. That tells about the lungs, and that usually comes together with the morphology of the atrial appendages. So it's all very nice to be able to show them, but you don't necessarily need to see the morphology of the appendage on the ultrasound. And most of the time, the thoracic situs is the same as the atrial situs, and is the same as the abdominal situs. But you can have discordance. You can have the thoracic situs being one and the atrial being different. But we assume here that they're all the same, because in the vast majority of cases it is. There is a rarity when there is discordancy between them. So when we have isomerism of the atrial appendage as assessed by abdominal views, there can be a lot of extra cardiac abnormalities. So you need to look for those things if you make the diagnosis of isomerism. And if you see some of these things, you have to think about isomerism. So the liver is, in the majority of cases, rather central organ. It could be more right-sided or more left-sided. The stomach quite often is central, but it can be either way. It can go to the right or it can go to the left. Asplenia and polysplenia in the two types of isomerism is seen in the vast majority of cases. Intestinal malrotation, well, can we see that on ultrasound? No, but it can obstruct. So if you have obstruction, you may have polyhydramnios, you may have small stomach, other things that may indicate there is a problem. And the appendix, again here, right, left side, or central, although I don't think we imaged that prenatally. Now, as far as the heart is concerned, there will be abnormalities of systemic venous drainage, very common, because the veins come to the atria, and if you have two atria which are right or two atria which are left, kind of the veins don't know where to go, so they go to the wrong place. So we have abnormalities of systemic and pulmonary venous return. So they're common. And quite often we have complex cardiac abnormalities. So have complicated hearts, think of isomerism. In the vast majority of cases, more than 50%. But sometimes some hearts can be almost normal or very simple lesions. So it's not all complicated. Now, when we think about the complex abnormalities, there's a very nice paper from Toronto which gives an outcome and spectrum of abnormalities in both right and left isomers, and I try to summarize some of the features here. So common lesions that can be seen in isomerism: atrioventricular septal defect, pulmonary outflow tract obstruction, abnormal ventricular arterial connection, total anomalous pulmonary venous drainage, extracardiac defects. So they can be seen in a large number of left isomerism. You see AVSD in nearly 60% of left isomerism, we have an atrioventricular septal defect. So all of them very common in left isomerism, but they're even more common in right isomerism. Pulmonary outflow tract obstruction, 91%. TAPVD, 73% of isomerism. So very complicated things, and they don't come in isolation. You have a combination of these in one single fetus. Now, there are other lesions, and these affecting some of them more the left side, like aortic interruption, not as common as the first ones I described, but aortic obstruction in about a third of cases of left isomerism. Interrupted IVC in the vast majority of cases, and heart block or conduction abnormalities. Why do we have conduction abnormalities? Well, the sinus node is a right-sided structure, and if we don't have a sinus node, the rhythm is usually an atrial rhythm or junctional rhythm and can go into complete AV block. So although they are seen in left isomerism, they can occur as well, but to less extent in right isomerism. Now, this is another review of left isomerism. It's a review of the own series from King's, done by Lindsay Allen, and all the papers that had been published up to end of 2009. And again, the kind of same group of abnormalities we're talking about in isomerism, left isomerism, interrupted IVC, which is one of the hallmarks of left isomerism, complete atrioventricular septal defect, all very common lesions. Right or left ventricular outflow tract obstruction, anomalous pulmonary venous drainage, again can occur in left isomerism. Malposition of the viscera, easy to spot, a lot of them, if you look for them, and heart block up to nearly 40%. I also put here bilateral superior vena cava are very common in both right and left isomerism. So let's try and summarize a little bit what kind of abnormalities we can get with them and how important they may be. So right isomerism, I think it's fair to say that all right isomers will have cardiac abnormalities. I'm not sure I made any strong diagnosis of right isomerism with no heart abnormality. As a group, compared to left, the right isomerism has much more complicated cases. And as a group, the prognosis is much worse in right isomerism than left isomerism. So it'll be very interesting how Rabbi would describe this heart to you in one word, as he wanted to take the myth away of fetal echo. Right isomerism. Central stomach, you have to describe everything. Central stomach, aorta and IVC to the left. Now, this is important to describe where they are because you need to follow to see where the blood is going to go to, because it could go anywhere. There's no rule. There are things that are more common. Heart on the right, Univentricular, atrioventricular connection, double inlet right ventricle, so 2 valves or sometimes 1 valve going to one ventricle. Double outlet right ventricle is a very common. AVSD's double outlet right ventricle is very common in isomerism. Pulmonary stenosis, complete AVSD with a common atrium and a common atrioventricular valve. Inferior vena cava to the right-sided right atrium. Bilateral superior vena cava, 1 to each right atrium. Absence of the brachiocephalic vein that connects the 2 of them. And total anomalous pulmonary venous drainage, infradiaphragmatic, obstructed. I think Rabbi was right. Poor prognosis. Yeah. Now, it's a long list, but you really need to think about each one and draw you a picture, build that picture in your mind to see where are the veins going to where, is the blood going the correct way, is there any critical lesion, what's going to happen. And the main critical lesion here on top of everything else is this infradiaphragmatic obstructed TAPVD on top of everything else. Is a very poor prognosis. So we do see that combination in one baby in isomerism, not infrequently. Now, left isomerism. Not all of the left isomerism will have a heart abnormality that will need attention. As a group, they're less complex than the right isomerism. And again, as a group, the prognosis is better than right isomerism. So not all of them are bad news. Let's just go through a left isomerism, a list of possibilities here in the same baby. So let's say we scan, we have to describe everything. Left isomerism, left-sided stomach, central aorta, left-sided azygos. Because we have to follow that azygos and see where that blood is going to get to. Heart on the right, biventricular, atrioventricular connection, that is. We've got 2 left atrium because we made a diagnosis of left isomers. We have 2 ventricles, and then we have to see where is the right ventricle and where is the left. So in this case, the heart is on the right, and the right ventricle is on the left. So you start building up your, apologies for the spelling here, concordant ventricular arterial connection. So the arteries are there, and they're coming off the correct ventricle. So this is more normal. That's why the prognosis is in general better. Now we have now an AVSD, but it's a primum ASD with 2 separate atrioventricular valves. We do have an interrupted inferior vena cava. That's where we started our diagnosis, with the azygos, that was there on the left, draining to a left-sided superior vena cava. Now remember, it's going to a left-sided superior vena cava, which goes to the left-sided left atrium, which connects to the left-sided right ventricle. So that azygos is going to the right ventricle, which is on the left. So you need to follow all of that. And then we look for the hepatic veins, because they're not joining the IVC, because there is no IVC. So we find out that those hepatic veins are going to the appropriate atrium, which is the left-sided one in this case, and that the pulmonary veins are also going to the appropriate atrium, which in this case will be the right-sided one. So once you've worked it out, all of that, this can be summarized in terms of hemodynamics as a primary ASD, because all the connections are going, although they're going through different pathways, they are going into the appropriate atrial chambers, which connected to the ventricles they need to connect to in terms of flow circulation, rather than the anatomy necessarily. And this is an example of such a case. This is a baby that was referred because of disproportion quite a few years ago. Right ventricle bigger than left, which it is. But if you look here, you've got an azygos. You have a primary ASD. Interestingly, if you look, there is no defect on the oval fossa. So this baby did not develop a hypoplastic left side here because he had a primum, I'm not quite sure if I'm generating this noise or not, primum ASD. So he had nothing else. All the other connections were good. It's just like what I described to you, and the baby only needed, at about 18 months of age, he had a closure of the primum ASD, and it's doing very well. At risk of rhythm abnormalities, but hasn't so far developed any of that. So I gave you an overall picture of what it is, kind of abnormalities that may come together hand in hand. So what to look for? There are lots of things to look for, and we had limited time. So I'm going to try and just sparkle some ideas for you to go back and start thinking about that. So again, we mentioned already earlier today, atrioventricular septal defect. You saw how common that is. So think isomerism. Don't assume AVSD is Downs. If the situs is normal, you have an atrioventricular septal defect, then yes, the possibility of trisomy 21 is very high. But if your atrioventricular septal defect is not with a normal situs, it could be the babies usually don't have Down syndrome or chromosomal abnormality, as Dario pointed out. Now, so you put a four-chamber view, atrioventricular septal defect, or go back and check your situs. Yeah? It should have been done in the first place, but if you forgot. So this is the same baby. Obviously, this was taken before the other image. So it might look a bit complicated, but just take one step at a time. Check the baby position, see where is the right, where is the left side, and then in this baby, this is the right side. Yeah, we see that there is a relatively small stomach here. If you look at that picture, you may think, is this the stomach? Is that the stomach? Not quite clear, because it looks small. You don't see a large stomach. It's only by seeing no flow in there and flow in this one that we know, or we wonder if that's the stomach that's on the right side. Also, if we draw our line here between the spine and the anterior abdominal wall, that's the aorta and that's the inferior vena cava to the same side. In addition, we have these funny vessels coming here, isn't it? So we don't normally see that vessel here. So what do they say about abnormal pulmonary venous drainage? Very common. So stomach in the incorrect place, two vessels to the same side, a funny channel here. So you have to think, well, this could be pulmonary veins going into the abdomen. So CNA VSD, check pulmonary veins. You have to check that in all cases if you're doing a fetal echo, but especially if you are thinking of isomerism, because abnormalities of venous drainage is common. So in this case here, you see there is a confluence here behind, this is all the same case. Behind the atria, you see a vein from the lung, so the heart was on the right here as well, and a vein from the left lung. Coming here, no connection with the heart, yeah? Then you have to follow that. Where is that pulmonary vein going to? It's going up to the SVC, it's going down the diaphragm. And in this particular case, we have a vein coming here, descending into the abdomen and eventually joining the portal system here. So this is a complicated heart with infradiaphragmatic TAPVD. So if a heart looks wrong, you don't have to think too much. It triggers your mind for isomerism. So complex congenital heart disease, lots of different associated abnormalities in the same baby, is isomerism. It's like seeing lots of problems with the fetus. If you see exomphalus, placental, you think of a chromosomal abnormality. Well, in the heart, if you see too many things in the same baby, think of isomerism. It may not be, but there's a high chance. So this one here, no one would pass this as normal. Very abnormal, four-chamber view, one big ventricle, one big valve, one big atria, two appendages. They both look the same to me. They both look like left. We don't always see them. In this case, we do. So it doesn't take much effort to say there is a complicated heart here. But in terms of prognosis, in terms of recurrence, it's important to make a full diagnosis. So this was a left isomerism with a common atria, as you can see, double inlet ventricle, all the two atria going to one ventricle, had a common AV valve, and it also had, not shown here, a single outlet heart with aortic atresia. So left side obstructive lesions happen not infrequently in left isomerism. Poor prognosis, again, in this case of left isomerism. Now, sometimes increased amniotic fluid, there's no obvious reason for that. Think about isomerism as well. Occasionally, newborns are born with a gut obstruction. They need neonatal surgery. And you go back to the history, and there it is, polyhydramnios unexplained, 32 weeks. And some of those can have a normal heart. So this case here, you can see marked right, stomach is on the right. fluid seems to be increased. I can't remember the gestation here. There's an atrioventricular septal defect there, unbalanced with the anterior ventricle being a bit bigger. And you also had double outlet right ventricle, pulmonary stenosis, bilateral superior vena cava. So the theme starts to repeat itself. One more. Unbalanced atrioventricular septal defect. So I've highlighted the things that are coming again. AVSD, double outlet right ventricle. You see here the two vessels coming parallel, big aorta. Unbalanced because one ventricle is bigger than the other. Common valve, two arteries, aorta bigger, pulmonary artery smaller, and right at the end we have bilateral superior vena cava as well. You see the azygos vein there. So just pay attention to all the details. Sometimes you see a complicated heart, you say, well, I can't deal with it, it's too complicated. But if you take one step at a time and start looking at it sequentially, surprisingly how often we can actually put two and two together. Now, when it's lots of those things associated, it's easy to think of isomerism. But cases like this that you probably see a lot, complete atrioventricular septal defect. This lady was already about 36 weeks when she came to me, having been seen already by someone else, made a diagnosis of AV septal defect at 21 weeks. She had the karyotype, came back as normal. She's been dealing with normal karyotype, complete atrioventricular septal defect. Can't remember why she was transferred to me quite late in the pregnancy, and there it was. See an azygos there? Aorta here, an azygos there. Check the situs. The situs was left isomerism from the abdomen. Yeah. One, the karyotype maybe could have been avoided. Two, the baby has a risk at some point, at all points in time, of having a rhythm abnormality. It doesn't usually happen, but occasionally they go into heart block, so maybe it needs a bit more monitoring from that point of view. And there's a little bit more recurrence risk if you have isomerism than if you don't have isomerism. So there are lots of other implications. Baby could have developed a gut obstruction during pregnancy, and then maybe, AVSD, polyhydramnios, people start thinking maybe this is Down syndrome. Well, it maybe it's a gut obstruction in isomerism. So just keep an open mind. Interrupted inferior vena cava, think isomerism. I think the problem today is that the machines are so good that it's very easy to see the azygos vein on your transverse sweep. Quite often you see the azygos joining the superior vena cava. But in these cases, the azygos is on the sagittal view, like here, almost as big as the aorta. And it's really a big chunky vessel that you see on your four-chamber view. You can see that very easily. So if you see left isomerism, interrupted IVC, think of left isomerism. In this particular case, there was no associated defect. And I think it's the next clip. So that azygos vein, you see a dilated coronary sinus. The heart was on the left ventricle was on the left, the right ventricle was on the right. The veins were going to the appropriate place. There we have our aorta and our azygos behind. Well, that azygos had joined this coronary sinus, which then drained into the right atrium, which went to the right ventricle, which then had the pulmonary artery. So there was no hemodynamic implication, and the heart was effectively normal, but with a risk of gut obstruction. You can have something called primary ciliar dyskinesia, which is related to the ciliar motility. There's a small risk of babies having that and having respiratory problems. So there are other extracardiac implications. We have the aorta coming off the left ventricle and the pulmonary artery. It's a bit dark, this one, coming off the... So otherwise, it looked like a normal heart. Now, it's one of my colleagues, obstetrician. Baby had an increased nucleotranslucency. Karyotype was normal in the first trimester, and it came back for a 16-week scan, a combined scan with the fetal medicine unit and a cardiac scan. And then he said, well, I think the baby has left isomerism before he came to me because I can see a big azygos. So that's the picture from the obstetrician, big azygos. But actually, when I start from the situs, which is the usual way we start the fetal echo, there are lots of things here. So think on the sides beyond just finding that the stomach is on the left, which it was in this case, yeah? So the stomach was on the left side, looks a normal stomach, normal position. But if you look closely, one will see a vessel here behind. This is 16 weeks. Aorta and a vessel behind, but also look at the vein here is turning to the left side. Well, normally we have that portal system going to the opposite side of the stomach. Yeah? So in here, not only you have the stomach on the left, but the portal system is going to the left, which is going along with the midline liver. Yeah? So sometimes subtle things there that may mean a lot. And that baby had a structurally normal heart otherwise. Yeah? This is another case that was referred because baby had ectopic beats. And for some reason it came to me, had bradycardia. So rhythm abnormalities are common and more common in left isomerism because the right atrium has the sinus node. And if you don't have a right atrium in left isomerism, you're more prone to rhythm abnormality. And if it is heart block, it's more easily people would think of isomerism on that. So the rhythm quite often in left isomerism is one-to-one. This is the way I look at the rhythm. You have a pulmonary artery and pulmonary venous signal together. This is atrial systole, and that's ventricular systole. So you have a 1-to-1, one atrium, one ventricle, one atrium, one ventricle. So most of the time it's regular. You can measure the atrioventricular interval. This is a little bit on the short side, but it's usually within the normal range. Well, this lady had periods of what sounded like ectopics, but actually were not. So at 21 weeks, baby during the scan would slow down to 70, not sustained, and then at one point went to about 55. So just atrial pauses. See here, that's an atrial systole, that's an atrial systole, comes here. It's not sinus because they don't have a sinus node. And then you have that long pause until something else takes over. It's a junctional escape rhythm. And in this case here, we had it, you waited so long before it started again, the rhythm went down to 55. So we're not quite sure if this baby was going to develop heart block or not, but it didn't. He went back settled around 100, 110 beats per minute. Again, in this case, with a structurally normal heart. I think this is the same fetus. When you go back into their abdomen, again here the portal vein coming into the same side as the stomach, and that's our vena cava, and that's our aorta. In this particular case, you can see here the aorta and the azygos, and we can see what seems to be a left appendage and a left appendage on both sides. That's a drawing of the appendage, so two left atrial appendages, which we don't necessarily need to see. Thank you.